Well, thank you for returning. I'm going to introduce our second panel of the afternoon with a focus on medical marijuana. And this time, again, I will just introduce generally the theme, and then I will introduce our contributors. The way I would like to introduce the theme is to note one very important discussion that's occurred in the last couple of days. Several days ago, a federal court judge struck down federal regulations restricting the rights of medical marijuana patients to grow their own cannabis, and this now gives the Liberal government 6 months to come up with new rules. This issue, among others, is the subject matter of our second panel on medical marijuana. To introduce the topic, I want to show you some coverage of these issues from Global News Saskatoon from yesterday, where a couple of people on our panel actually make the news story. So I'll just show this to you. All right, so given these events which may come up in our panel discussions, this seems to be a timely topic for us. So let me introduce the people sitting on this panel. First of all, we have once again, as serving as moderator, Lucas Richert, who now needs no introduction. Second, and presenting first is Murray Updahl. He graduated from the College of Physical Education prior to going into the College of Medicine at the university here. He worked as a family physician for 12 years, but in the last 8 years has been working as a physician with an interest in chronic pain management. Secondly, Marjorie Delbert. Marjorie Delbert is an associate professor of marketing at the Edwards School of Business here. Marjorie's program of research explores the interplay between the persuasive use of language and images and consumer knowledge transfer in the marketing of controversial products, such as prescription drugs. Third, Brent Zettel, who we've seen on the video. He is a pioneer of medical marijuana, CEO of Prairie Plant Systems and Canimeb, a medical marijuana producer outside of Saskatoon. And so I'll give it over to you all as we listen to you.
I think you want me to go first. Well, Lucas gave me permission to use a PowerPoint presentation, and I will really do my best to keep this brief, but I thought that these slides might help you understand the perspective that Canadian physicians, where we come from in terms of this area, in terms of medical cannabis. And I need to say right off the bat that I'm here to hopefully educate you and give you some insight in terms of how physicians perceive this very important topic. I'm not here to generate new referrals or to find new patients. My practice is closed and I don't see people specifically for medical marijuana. So just so I start with that. My objectives are to discuss why medical cannabis is such a controversial topic for physicians and why many physicians are reluctant to authorize this remedy. I'm going to give a brief overview of available research, some treatment guidelines, educational materials that physicians have access to related to cannabis. And I'm going to briefly discuss the steps that physicians need to do to provide a medical document that authorizes our patients to purchase marijuana for medical purposes. So this all comes down to the court and the regulators in Canada in terms of the prevailing government. In 2014, on April 1st, the new regulations that they call Marijuana for Medical Purposes regulations came into play, and it put physicians in the uncomfortable and unwanted role of the sort of gatekeepers of medical marijuana. And so each physician who decides to authorize their patients can produce this medical document. It's not really a prescription, it's more an authorization then for the person to purchase marijuana for their medical condition. These regulations say the physician can authorize up to 5 grams per day of the dried cannabis. At that time there was no ruling on oral or edible products, and we can authorize up to a maximum of 12 months, and then these patients need to be reevaluated in a new medical document. At that time, it changed significantly because Health Canada really pulled out of the whole process, and there was no authorization from Health Canada, but rather just the doctors. And so there was no specific medical conditions anymore that kind of qualified like the system before. So here's a few slides to discuss why physicians are reluctant to authorize cannabis. And it's based on multiple medical associations and the current available published evidence for cannabis as a medical therapy. So it starts right from the top at Health Canada, which is similar to the FDA in the United States, that they're the arm of government that authorizes medications and other substances, saying that they're safe for use and our patients can use them. So if you look in this kind of rectangle, it more or less says that they say dried marijuana is not an approved drug or medicine in Canada. The government of Canada does not endorse the use of marijuana, but the courts have required reasonable access to a legal source of marijuana when authorized by a physician. So this arm of government was trumped by the courts, and they needed to create some regulations to guide physicians in terms of authorizing marijuana for medical use. Now, one of the major sort of associations of physicians in Canada is the Canadian College of Family Physicians. And this is a group that looks after education programs, and almost every family physician in Canada is a member of this association. And they came out very clearly and said Health Canada places family physicians in an unfair, untenable, and to a certain extent unethical position by requiring them to prescribe cannabis in order for patients to obtain it legally. Health Canada states the indications, should explicitly state the indications, precautions, contraindications for medical marijuana as they do for all other medications. So the Canadian Family Physician said, this really isn't a prescription. This should be more of a declaration or an authorization for patients to purchase marijuana for their medical condition, rather than a prescription that suggests that the physician has recommended the patient use it and suggested a specific dose or directions on how to use it. Now, another big association, which is really all physicians in Canada, including all specialist surgeons, family doctors, is the Canadian Medical Association. And again, this is a very busy slide, but it suggests that the Canadian Medical Association recommends caution in terms of use of marijuana for medical purposes. But I think this statement is quite good. While acknowledging the unique requirements of patients suffering with terminal illness or chronic disease for which conventional therapies have not been effective and for whom marijuana may provide relief, physicians remain concerned about the serious lack of clinical research, guidance, and regulatory oversight for marijuana as a treatment. They go on to say how complex of a substance marijuana is, and we don't have sufficient clinical and basic science to provide this as safely as we would with other medications where we have all kinds of studies in terms of safety, drug interactions, benefits, and so forth. So they say there's a need for unbiased, accredited educational modules and decision support tools based on the best available evidence to help physicians. So the Canadian Medical Association went on in a debate in this particular article, and I'll just tell you a couple of other comments that the Canadian Medical Association is telling to physicians. The Canadian Medical Association has consistently opposed Canada's approach, which places physicians in the role of gatekeeper in authorizing marijuana. Physicians should not feel obligated to authorize marijuana for medical purposes. And physicians who choose to authorize marijuana for their patients must comply with their provincial and territory regulatory colleges' relevant guidelines or policies. So in Canada, physicians have chosen, and we have the privilege of regulating ourselves. So physicians are regulated in terms of their behavior and standards of conduct by other physicians, and they're called College of Physicians and Surgeons. And these are, every province has a different College of Physicians and Surgeons that kind of makes up their own regulations and bylaws. And so this slide just shows that each province has a little bit different take on what bylaws or regulations physicians need to live up to. In Saskatchewan, we have a very good document that was created, and it's based on a bylaw from the College of Physicians and Surgeons of Saskatchewan. It more or less says physicians should continue to have a very high standard of medical care, If you are going to authorize someone for medical cannabis, you should be very thorough. You should evaluate that patient's medical condition, their past medical history, past treatments that they've had, whether they were helpful or not, how they tolerated them, and in particular doing an addiction screen to know what the risk of addiction is in that patient. Because we do know that some people do develop a cannabis dependency that can really change the quality of their life. So Saskatchewan has guidelines that say we need to keep very good documentation. We need to see our patients on an ongoing basis. There should be a formal doctor-patient relationship. It shouldn't be just a one-time thing to see the doctor and you get your authorization for 12 months and they never see you again. That's not appropriate when it comes down to any sort of treatment that is prescribed or authorized by a physician. So here's just a brief summary of information on medical use. And there's a huge Canadian component to this. If anyone is interested in kind of reading an article that has an excellent summary of kind of the history, the current evidence, I would highly recommend this article from Dr. Mark Ware from McGill University. It's published in the International Association for the Study of Pain, sort of the world journal in terms of pain. And it's called Medical Cannabis and Pain. And Dr. Ware goes through the whole history, going back and in terms of summarizing some of the research that's available. And some of the comments that he made in this particular publication were quite telling. One of the comments was that we're really not going to be able to get large phase 3 trials in human beings with the current environment around marijuana, particularly with the worldview against anti-drug, anti-smoking, and also that there's no sort of availability for high-quality cannabis products to be studied, particularly in the United States when it's still a Category 1 medication or drug that is felt to have no medical purposes. This particular slide just shows that there are studies that have been published that are randomized controlled trials, which is the highest quality of evidence. Majority of studies for cannabis derivatives or cannabinoids are in the nabilone capsule, and they've studied it in neuropathic pain, fibromyalgia, spinal cord injury, diabetic neuropathy. They used to have one called Marinol, which is called dronanabol, but that's been taken off the market in Canada, but it's been studied in multiple sclerosis, spasticity, chronic pain, spinal cord injury. And then the other one on the far side is a spray that's in the mouth called Sativex, and it has probably some of the best evidence in terms of treatment of neuropathic pain, spasticity, and cancer pain. There's really only been 6 really well done RCTs in inhaled cannabis. And these do show a trend for benefit in terms of conditions such as HIV-related neuropathy or other conditions where the nerves have been damaged or malfunctioning, or in MS or in Crohn's disease. So there is some studies out there, and Dr. Mark Ware in this particular paper says physicians that go with the statement to their patients that, oh, we just don't know enough or there's not enough information, may not be the best thing for that doctor-patient relationship, because there is evidence for some benefit, and it should be a remedy that's discussed along with the more traditional pharmaceutical and non-pharmaceutical treatments for these really difficult to control conditions. So here's one of Dr. Ware's studies that was really well done with actually a placebo type of marijuana that had 0% THC, and one that had about 5% and one about 10%. And it showed that the stronger cannabis, the stronger THC types of cannabis did provide improvement in these patients' pain. This is a more recent one that was just published in December from Dr. Ware and others that really talked about safety with a very well-controlled, quality-controlled herbal cannabis when patients who had experience with cannabis used this as part of a monitored treatment program over 1 year, it appeared to have a reasonable safety profile. So no really scary, dangerous adverse effects occurred with it. There was nuisance side effects, which are common with an inhaled substance. And so it suggests safety with this particular agent in medical cannabis users. But he definitely made it clear that longer-term monitoring for functional outcomes whether the cannabis actually improved people's ability to function is necessary. This is a lady from Canada, Mary Lynch, that published another systematic review that said it's reasonable to consider cannabinoids as a treatment option in the management of chronic neuropathic pain with evidence of efficacy in other types of chronic pain such as fibromyalgia and rheumatoid arthritis. Here's a couple other studies from the United States that suggest there is some evidence. Now, the College of Family Physicians of Canada created this 28-page document in terms of giving doctors information on prescribing. And they give 15 recommendations on how to prescribe and how to do it safely. If anyone's interested in really good online information about cannabinoids, this would be the site that I would highly recommend, the Canadian Consortium for the Investigation of Cannabinoids. It's a non-profit organization concerned with evidence-based research. And due to time, I'm not going to go into details about how doctors actually authorize this, but there's a number of steps that the physician needs to do to ensure that the patient understands the risks of potential marijuana, and then we can sign this medical document that can authorize them to use it. But we need to follow up these patients regularly to make sure that they're using it appropriately and there's good benefit. So thanks very much for your attention, and I'll turn this off.
Thank you. Just to preface this, and just so you know that we're being fair here, we did have a discussion that some of the other panelists would cede a couple of minutes. So, Marjorie?
Yes, and I absolutely promised Lucas that I would keep it brief and I would donate some of my time to our previous presenter. I have no medical expertise whatsoever, but I have spent an awful lot of time looking at ads for prescription drugs. I don't know if that gives me a little bit. I know a lot about the marketing of legal but controlled substances. And I find this area fascinates me, partly because of the controversy and also just because of that potential for using marketing tools and marketing concepts. I think it's interesting both from, we talked a little bit about the image problem that cannabis has, and I think marketing, a lot of concepts of marketing could be very useful in influencing opinions in either direction, so depending on your stance. But marketing frameworks are also really interesting when we're trying to understand and plan for the potential eventual legalization. And it's really interesting to think about it from a segmentation perspective, which I won't bore you with all the theory behind that, but if you're interested, I think that's essentially what we've done. Even with this panel, we've got recreational cannabis versus medical cannabis, and that's really at a lot of the core of marketing strategy, is developing that segmentation because different user groups have different needs. So I see a lot of application potential for this in terms of understanding just the business side of it, but also understanding opinions, and if we do want to try to influence opinion change, I think we can look to a lot of things from the marketing side. Is that short enough?
Yes, by all means, it's great.
I'll be really short. I think everybody knows what I do, so I don't need to say anything more, right?
Okay. That's much shorter than I thought. Well, what that does is it allows us to have questions from the audience. So let's go straight to that then. We have already one here, and then we'll go here, okay?
I just have a question for the panel. Just seeing in the future, how will people's jobs be affected by the use of cannabis, legal or not legal? Is there going to be laws or policies in place for people who are discriminated for usage? Just a personal story, I know a friend up north, I work in the oil and gas industry. He was in a little incident. He ran over something with his machine. Not a big deal, it was something small. He was tested for drugs and alcohol. Well, he had a medical marijuana card and was fired on the spot. When he asked why he was fired, it was because he had marijuana system. Even with the card, they found another reason to fire him, essentially. They just found this other stupid little reason.
So I'll summarize that for everyone, and then I'll give the panelists a chance to answer. So summarizing that, is there a stigma attached to the medical use of marijuana, and how is that going to affect people in the workplace moving forward? I think I'm doing your question justice.
Yes, absolutely. Or like even not being able to pick up a job.
Not being able to pick up a job afterward. Right. Okay. Thank you.
You know, as an employer, we look at the terms of the medical access for patients. So if there's a true patient that has the appropriate medical documentation and they're truly using it as a medicine, then as an employer, especially within Saskatchewan now, we have to respect that they're going to be allowed to use their medicine when they need to use it under the physician's directive. The challenge becomes is in working with heavy equipment. And there isn't good data that we have that demonstrates when a person who takes and uses and medicates with any kind of narcotic, particularly cannabis in this case, and what's the safe level within the blood that people can operate machinery with. And it probably means that with all of the bugbear around medical cannabis and in the trying to crack down on drugs within the safety aspect for operations because of the lawsuits that hurt from harm of other co-workers, they're going to err on the side of caution until we sort of get better data about what the safe levels are going to be. And I think it's a bit of a prejudice at the moment, but I don't think it's going to stay there forever. But we do need to have enough information as employers to know what the safe level is for people to be able to operate machinery and function in a work environment. We don't know that yet, and I think they're erring on the side of caution at the moment.
People are getting fired without operating heavy machinery for urine tests.
Right. I wonder if I can comment too, because as a physician who looks after people with chronic pain, I prescribe a lot of medications that may have an effect on their ability to be safe, whether it's operating a car or heavy equipment. And I'm all about safety because I also look after a lot of people that have been injured in work-related accidents. So I think it comes down to the similar question before about how the police are going to regulate impaired driving. It really comes down to if that individual is impaired at the time that that accident at work happens or that he gets pulled over by the police officer, there needs to be better evaluations of impairment and whether they're safe to operate that machinery. It's not whether that substance is in their body, because as many of you know, there are people who use marijuana on a daily basis and they're not impaired at all, and you cannot tell that they have it in their system. Now, it's different if they just had 10 joints and they're a novice and they go out and they can barely see the road and they're so paranoid they're going 20K in a 60K area and they get pulled over. They should be charged with impaired driving. Now, in terms of the workplace, my understanding is some employers have policies that are just completely no drugs, zero drugs. So that will limit people that have a medical authorization to purchase marijuana because they have to use that substance for their treatment. But they may not, if they disclose that to the potential employer, they may not be accepted for that job. But doesn't necessarily mean they're going to be impaired when they have that substance in their body. So this is all going to translate over time in terms of more case law and more evidence, because if medical cannabis is authorized, and especially if now people can grow their own, we need more time and more sort of evaluation of this.
Right here?
Yeah, so Murray, just a question for you, just on your knowledge. With the College of Physicians for Saskatchewan, they put a restriction on the number of prescriptions a doctor can give without having to report it. Then after so much, they have to report it. Now, who came up with this number for the College of Physicians? Was it all the doctors, or was it a group of people who made this restriction to them?
So great question regarding whether physicians have to report when they authorize patients. My understanding is when the regulations changed and physicians became the gatekeepers, the College of Physicians and Surgeons just came up with that themselves. It wasn't other doctors, it was the sort of head office of College of Physicians and Surgeons. And my understanding is if a doctor has authorized patients to purchase medical cannabis, if it's less than 20 people, you only have to give that information once a year. If it's more than 20 people, then you're supposed to tell them how many patients and give the medical document about those 20 or more patients. So it's just an arbitrary number because they feel that there's really no way for them to regulate medical cannabis compared to, say, other prescription medications like opioids or whatever, where the pharmacist puts that into a pharmaceutical information program and every doctor and pharmacist can look that up. So the arbitrary number is 20, and you just have to submit that information.
There?
Just talking about the efficacy of the prescriptions and whatnot, we see a lot of people all the time that talk to us and say that the doctors are telling them that they're not authorized to prescribe it and they're not qualified to prescribe it. Now, is that going to be a big problem in the future, and is that a little bit biased or discriminatory towards people?
I hear your comments, and I think it really comes down to some of the information I presented. A lot of doctors do not feel comfortable with it, and rather than just saying, you know, I'm against it or I don't feel comfortable with it, they might say I'm not authorized, but really every physician in Canada is authorized if they have a license. In my opinion, it would be better to get into a discussion about other treatments and where the cannabis comes in terms of their treatment. But you're right, it creates a lot of difficulty.
Murray, can I have a follow-up with that one? So you mentioned in your presentation, it was a very interesting phrase, doctors now had an unwanted role where this power was being forced on them. And so I was wondering if you could talk a bit more about the debates, about what this actually means.
Right. Well, that's again, the whole gist of my presentation was that all of these associations are telling physicians to be very cautious. Before April 1st, 2014, there used to be a process where the physician would complete a form saying that their patient did have a condition like a spinal cord injury or severe cancer pain, severe arthritis, that satisfied Health Canada that it was a condition that they could authorize use of marijuana. But after April 1st, 2014, Health Canada got complete out of it, other than authorizing which licensed producers were allowed to grow the product and sell it. And so physicians didn't want that whole responsibility because it's completely on the physician's shoulders. Mm-hmm. And so a lot of people just got angry at that and said, well, I'm not going to authorize. And that's fair. They have that right, because even the associations say you shouldn't feel obligated to prescribe. Mm-hmm. So it was very much forced on us, mm-hmm. and was very unwelcome to most physicians. Mm-hmm. So a different system might be a lot better.
Here?
A couple comments and one question. Talking about not knowing the effects of marijuana and the research and whatnot. I know as a nurse when I'm giving a patient literally a handful of pills, I'm pretty sure they haven't been researched, all being given together, you know, with 16 or 18 pills at a time. And I'm wondering, too, like you made the comment that you assess and advise the patient for addiction for cannabis. I'm surprised to hear that. I don't think that's currently being done with opioids, which is, again, as a nurse, I rarely see a lot of issues that way. But the question is, and if I've understood you correctly, all doctors can prescribe cannabis and are reluctant to. Are they looking to have a system like for methadone where you have to apply to Health Canada for an exemption, where you have the education? Is that be more palatable for them, and then they wouldn't be authorized unless they undergone that?
Those are all awesome comments and questions.
Is that what they're proposing, though? That last one is a question. Is that what they're proposing? That
well, I'll talk on all three of your statements, actually. The idea about interactions with other drugs, from what we understand of the cannabis and the cannabinoid, and there's probably many, many different cannabinoids within cannabis, they're actually not proteins, but more fatty acid type things. So they are less likely to have any specific drug interactions where it will elevate a drug. Like say, for example, methadone, if someone takes an antibiotic like Cipro for a bladder infection, methadone levels go all out of whack. So it doesn't have that type of drug interaction, but if people are on other sedating substances, like you just mentioned, people are on a handful of different drugs, those other sedating drugs might be amplified when people use cannabis. So you have to be careful when you start it in a person who's already on multiple drugs. And I'm sad to hear that you feel that physicians aren't screening for addiction when they prescribe opioids, because it's really highly recommended for everybody. Our new Canadian guidelines for safe and effective use of opioids really suggests if someone needs long-term opioids, please screen them very carefully. And we have some tools like the opioid risk tool that we should all be using before we prescribe opioids, especially long-term. Now, in terms of what the physicians would like the system to be, I'm not aware of any discussion. I really just think physicians don't want to be the sort of the gatekeepers of it. And so I don't think we're looking for a methadone type system where we have to get authorization, because I don't think any doctors would want that authorization.
Back there?
I noticed there, you said something about drugs and research is not done with cannabis. When you look at some of the past instances with like Pfizer, for instance, they've had a lot of scandals, and haven't they done research on those drugs before they came out? Like, we've been kind of using marijuana on and off for a long time. I feel like...
So, rephrase the question.
I feel like we should maybe be a little bit more... I don't know, the doctors seem a little bit scared to give it away, and I don't think they should be as scared. For instance, like, other drugs have been researched way more, and they can cause way, way worse problems.
Potentially, some prescription medications can cause way more problems, but they're studied in very major long-term trials and lots of people. So I wouldn't say that prescription drugs are safe or haven't caused harm, but you're right, physicians, I wouldn't use the word scared, they're very reluctant to prescribe based on the small amount of information that has been published. And to your point about why it hasn't been studied, like Dr. Mark Ware says, there's no real intellectual property. This is a plant, unless it's kept to the licensed producers that will create a very safe and clean and consistent product. If it's a product that people can just grow, well then doctors are completely out of the loop in terms of knowing what's safe and what's gone into it, or what's pesticides have been put on it, or if it's infected with bacteria or fungus or whatever. So there's a lot of issues.
Before we take another question from the crowd, I'm going to ask one myself. I've written a book on the pharmaceutical industry, and so Marjorie, I wonder, you also have studied the marketing of pharmaceuticals quite extensively. Looking ahead, how do you see marketing campaigns rolling out for some of the licensed producers in Canada? Do you have general thoughts? Do you have specific thoughts? How could this play out?
I have general thoughts, not specific thoughts, but I think it comes down to how it's positioned. So if it's positioned as therapeutic treatment, then we can probably look to other, we have a lot of regulations even for natural health products and how you can advertise those in Canada, and especially for prescription therapeutic products. And in Canada, you're supposed to, really only if you're advertising them direct to consumers, it should be limited just to either price or price, brand name, and quantity. You're not supposed to go beyond that, but we can see in the States, and we get a lot of the media feeds from the States, that they go far beyond that. But the American Medical Association just recently came down with, I guess, a recommendation that we should ban all direct-to-consumer advertising for prescription drugs. So it's a heated debate about a legal controlled substance, and so I can only imagine going forward. I think if we follow that, the medical marijuana route, and that's how it's positioned, I think we have already some regulations around how we advertise and how we market other products like that. But I think the issues of control will probably be paramount, and how we, who we allow to be the sources of the message, and then the content. So is it informational or is it persuasion? And that's a huge debate around it. And the research that I have done, I looked at drug ads that were directed to consumers, but also to physicians. And both of them were mostly persuasive in nature, and they contained lots of conceptual metaphors in both of them, also the ones directed to physicians, oddly enough. And so that was really surprising. So I think it's really hard to draw the line between what's informational and what's persuasion, because I believe that most information has to be presented in one way, and you choose one way that you believe is most persuasive to accomplish your communication goal. So I think there are different models that we can look to, but it will be interesting to see how we proceed.
It's probably pretty persuasive if you fly doctors to an island resort and give them free golf trips and cases of scotch.
Well, we should ask our physician. Yeah, but they're trying to be preemptive or preventive and self-regulate as well by saying we shouldn't be accepting those offers anymore, and then the prescription. Pharma, it's an acronym of the pharmaceutical producers in the U.S. They also have their own code of conduct now that says you should only be giving or delivering educational materials. And so they're trying to stay ahead of the game a little bit there.
I wonder, Lucas, if I can just make it very clear, in Canada, the sort of XandD Guidelines is what the pharmaceutical companies call. The pharmaceutical companies regulate themselves. There is no more going to islands. There's no more fishing trips. There's no more cases of scotch. No more computers for doing the study. It's become extremely the other way. We can hardly even get anybody out for educational things because all the pharmaceutical industry can offer is a meal when there's when there is a educational event. So all of that old school stuff, that is no more.
Thank you. Thank you. Question here first, and then, go ahead.
I'm going to preface this by saying I used to live in Vancouver, where the discourse surrounding marijuana is like a bit more lax. And so I was there in the early 2000s. I had a friend who was HIV positive. I would go to Compassion Club and get weed quite easily. It was prescribed by his doctor and stuff. And you were talking about hesitance and doctors sort of being thrust into this unwanted role of being gatekeepers. Would it be fair to say that that's more of a cultural frame because we're in Saskatoon, where we're maybe a couple of decades behind a place like Vancouver in terms of that? Like if you were practicing out west, it could potentially be really different, and it wouldn't necessarily. You probably wouldn't be saying that physicians were in an unwanted position, or do you think it's more like across the board?
So I'll just paraphrase so everybody hears. Do you think the culture among physicians is different in BC, where there's thousands of people that are authorized to purchase, and there's the compassion clubs and dispensaries, versus Saskatchewan, where we may be decades behind? I don't know. I can't speak to that. I've never worked in BC. I just know my colleagues around here, and I know what the national associations, including the Canadian Medical Association, the Canadian College of Family Physicians, what they're saying. So I can't really comment to the culture within physicians from province to province.
So was it here? Oh, there.
I was just say, Murray, towards your comment towards, doctors wanting to be framed in a certain way for to know exactly what's in the prescriptions and whatnot. There's been a lot of stuff on the media lately as of LPs have been having what they say is on the label is not what the product test says. So what I'm saying is there's a lack of continuity in this industry right now. And in that, I mean, even in the Allard case, as to reference one of the testimonials, we eat apples every day. We're encouraged to eat apples every day. They use pesticides on apples a lot, and they don't control that or regulate that. And we ingest that the same. So is it kind of, for lack of a better term, apples and oranges type thing?
Maybe. But I didn't really get a question.
The question is, I guess, why is there a difference between what doctors or what, I guess they'll say, society will say about what you can put into an apple, but all of a sudden once it's marijuana or once it's not grown by an LP, that it's no longer good because what the person's putting in. So if the person's growing it at home, they're probably not going to put any pesticides or insecticides on it when they're growing it themselves. So to say that that's the only framework that would follow helping people when it's been proven that their guidelines or their labels don't match what it actually tests for.
Well, I definitely like Brent's opinion on this too, but I think your apples and oranges is right, because physicians don't have any control over what foods are available or the manufacturing or the growing principles, but we are asked to say whether marijuana is the right choice for our patients. And so there's a whole bunch of other issues in terms of, do they have lung disease? Are they a woman who's potentially going to get pregnant? Do they have a family history or a personal history of schizophrenia or psychosis where, yeah, that substance is not a good idea for them? So I think when it comes down to authorizing a substance when it's going to be used for a medical treatment, that's different than just authorizing food. So I might ask Brent to comment on the pesticides and the safety where a licensed producer is supposed to create a product that is testable. You can show what the percentage of THC, what the percentage of CBD, and that there is no heavy metals or fungus or bacteria. I might ask for your opinion because I understand your comments.
Well, I think I'd start by saying that the old adage, an apple a day keeps the doctors away. So that's part of the problem, right? Just kidding. So the reality is that if you look at the system right now, there is, I think, there's been 5 product recalls already from different LPs, and ours hasn't been one of them. But it's because of that standardization question that all the material is supposed to be put into a lot, and it's supposed to be tested for not only cannabinoids, but as we do, we have 281 points of quality control, metals. It has to be tested for microbial loads, et cetera, et cetera. And it has to meet the certain standards, right? And if it doesn't meet the standards, then it doesn't. Now, in the case of cannabinoids in our system, and we don't speak for all the LPs, but in our system, we follow the British Pharmacopoeia. That's why we have the test results. And it has to fit in with about a 15% confidence interval in terms of its tolerance. And if it doesn't, it's not included in the lot. And that's because it has to match the product label. And in the case of a true drug, if it doesn't match the product label, that's why the recalls happen. And Health Canada is starting to catch the guys that are sort of trying to skate around it. Now, part of the challenge you have with medical cannabis, and why the reason we mill the material and destem it, is because to get a consistent product throughout the volume, you have to have a consistent amount of stuff. And what we found in our tenure when we were working with this stuff, that there's actually quite a large variation in the cannabinoid content from the top of the plant to the bottom of the plant, what we call the immature buds versus the mature buds. And we know that in the development of cannabinoids in the plant, the last 10 days are like where the maximum amount of cannabinoids are being laid down in the oils. So it's kind of like a curve, and in the first part of it, it starts very, very low. And it's we have a 96-day cycle. And in those last 10 days, it can go from, say, a plant that's supposed to mature at 14%, 7 days before, it'll only be half of that. So, but the problem is it ripens from the top to the bottom. We have a very succinct. In the bottom of the plant, those immature buds, as we call them, are about half the strength of the ones that are at the top. So in order to get a very consistent product, you have to be able to, when you blend it, you have to test it to make sure as a lot it's consistent. Now, if you're supplying material in whole bud material, right, the problem is that you can't get away from that variability from within the plant itself or plant to plant. So that's why I think that's part of the reason why they're getting off label. Now, that saying that, the obligation is on the LP to make sure that it is within specifications of the label. That's the law. And so that's why there's been some product recalls. There's been some other reasons, but that's been one of the reasons. So to your point, that's the way they're supposed to do it. And we're being held to that standard to make sure that it is what's inside the bottle is reflected to be in the bottle.
And I'm sorry, folks, but that is the final word. I must say, thank you very much for attending. Thank you. It's been great. Please thank all the panelists individually if you would like.